Hello everybody, this is part 2 of lecture 5. We just got done talking about post-traumatic stress disorder and now we're moving on to acute stress disorder, or ASD. Um, ASD has the same criterion A as post-traumatic stress disorder, which was the exposure to a traumatic event that has real or threatened serious death or serious harm or death or sexual violence attached to it. And there was a variety of different ways someone could be exposed to this type of threat or actual experience, either vicariously or directly or from hearing it through somebody else. Moving on with more about ASD, there's also the presence of 9 or more symptoms from 5 particular categories, which is 14 symptoms total that someone may have with acute stress disorder. I don't have them all listed here in the slideshow, but basically most of these symptoms under ASD are similar to the symptoms that are all a part of PTSD. Now we saw in PTSD that the symptoms are branched out in 5 different clusters, right? Well, really 4 when we have the same criterion A, right? There's also B, C, D, and E that come along with it. And basically with acute stress disorder, they've just clumped all of those symptoms onto just this cluster B here. One thing that's different about ASD in particular that from PTSD is the duration. Acute stress disorder can only typically should occur within 3 days to 1 month. Any longer should be assessed for PTSD, because longer than that, we would go into the duration that is expected of PTSD, right? So PTSD, these symptoms have to be going on for at least 30 days, where with ASD, it can only range from 3 days to 1 month. Any longer, and we have to think of whether or not this is actually acute stress disorder, or is this something more long-term like PTSD. Now, one other important detail to keep in mind diagnostically is that roughly 50% of people who develop ASD will later develop PTSD as well. So ASD is a very strong warning sign that somebody will ultimately develop PTSD and likely require further treatment. Moving on from ASD, we have adjustment disorder. This is just in general a good disorder to keep in mind. Typically, this diagnosis is used when somebody appears to be struggling significantly with a major life change, and there's no specific diagnosis that you can think of that the individual fits with. All you really know is that there's something going on in their life that is really impacting them severely. So we look at criterion A, development of emotional or behavioral symptoms within 3 months of an identifiable stressor. So that's really the crux of adjustment disorders, that there is an identifiable stressor that has not yet resolved. It has to be still ongoing, or maybe it had been resolved 2 months ago, but basically these symptoms are occurring while this has not been recently resolved yet, whatever this identifiable stressor is. Symptoms are clinically significant, evidenced by one or both of these two things: the stress that's out of proportion of the stressor itself, considering also external and cultural context. So basically, this is kind of like when we were talking about phobias before. The reaction this person is having is above that of what would be expected of a normal person. Just like with a phobia, the fear response is above that of what the actual threat level of the thing that they're afraid of is. There's also significant impairment in social, occupational, or other areas of functioning, and it does not meet criteria for another disorder that it would better fit as. Also, it does not represent normal bereavement. We talked a little bit about bereavement versus depression in the past as well. And symptoms do not persist more than 6 months beyond termination of stressor. There's a variety of subparts that come along with adjustment disorder. This can also be with symptoms of depression or symptoms of conduct issues, or a mixture of depressed or anxious or conduct issues as well. If you look into the DSM-5, you'll be able to see more of that. In fact, I'm a little bit curious myself to see what those subtypes are. So let me just take a quick look in here to find the, oh, you know what? Where is the adjustment disorder? Let me read these out for you right now. Here are the specifiers for adjustment disorder. With depressed mood, so these are all the accompanying things. So with this one, it would be low mood, tearfulness, or feelings of hopelessness are predominant. There's also with anxiety, which is nervousness, worry, jitteriness, or separation anxiety is predominant. So a strong amount of distress about being separated from somebody who is considered an attachment figure. With mixed anxiety, so here's number 3, with mixed anxiety and depressed mood. Number 4 is with disturbance of conduct. That one's listed as disturbance of conduct as predominant. They really don't give a very deep explanation for that one. There's also with mixed disturbance and emotion, mixed disturbance of emotions and conduct. And the last one is unspecified, which is for maladaptive reactions that are not classifiable as one of the specific subtypes of adjustment disorder. So we see a lot of different specifiers for this disorder as well, but primarily we see depressed mood, anxiety, and some sort of conduct disturbance are the primary things that would be attached to this type of diagnosis. But keep in mind the main crux is just that they're having difficulties above normal proportions to an identified stressor that hasn't yet resolved. Alright, so moving on to dissociative disorders, we're looking at dissociative identity disorder, dissociative amnesia, and depersonalization and derealization disorder. First off, dissociative identity disorder, or we also just call DID for short, which is a disruption of identity that involves discontinuity of self and sense of agency. 2 or more distinct personality states exist. Alterations in affect, behavior, consciousness, memory, perception, cognition, and sensory motor functions are occurring. Some cultures may consider this a form of possession. There are recurrent gaps in recall of everyday events. This is not a normal part of broadly accepted cultural or religious practices. So when you put all this together, this used to be called multiple personality disorder at some point. But we don't really think of it that way anymore. The DSM-5 tries to be a bit more objective with its description. So we see that somebody possesses, one way or another, more than one distinct personality state. And when they're in these different states, they're exhibiting a major change in how they express their emotions, the general behaviors that they engage in. Their very consciousness may be different. Their memory may have gaps in it from one state to another. That's what we mean by discontinuity of self and sense of agency, basically, with this one, is that it is very much like somebody is separating into another personality that they are not consciously connected to. There's a lot of controversy about this disorder, whether or not it really happens or whether this is more so just some sort of defect in memory that occurs during states of internal stress, or somebody simply just doesn't remember certain aspects of how they possess when they are being stressed. But I also know experts, especially in the Kalamazoo area, who treat people with this and feel very strongly that there are separate states, personality states that exist or coexist within one person. And there is just a very wide variety of theory and treatment modalities for this particular disorder that I'm not going to get in too much depth with. What's really important to know is that, with a co-occurring disorders class like this, is to really consider whether or not somebody is, for instance, blacking out, right? We know that with alcohol disorder, it's possible to experience blackouts, which is once you are to a certain level of intoxication, your brain is no longer coding the proteins necessary to create memories. And so blacking out is a very similar idea. You're in an altered state, right? You may even take on different personality traits when you are intoxicated on alcohol than when you're sober. On top of that, you may also not remember many of the things you did the night before because your brain has basically been compromised, at least in memory-making abilities, while you were intoxicated. So a very important thing to be able to keep these two disorders separate from each other as well. Okay, so here's another thing that's in the DSM, dissociative amnesia, which is the inability to recall important biographical information, so basically your own self-narrative history, which is inconsistent with normal forgetting. It's usually related to traumatic or stressful moments that are forgotten, and maybe localized, selective, or generalized. So generalized would be about really not remembering who you are sometimes. There's a specifier for this disorder, which is experiencing a dissociative fugue. What a dissociative fugue is basically somebody may catch you doing something that seems like apparently purposeful travel or wandering. But you are not necessarily consciously aware. You are in almost a sedated state, and you may not be woken from it until somebody approaches you. Now keep in mind, this is not sleepwalking, though. This is not, you are not actually in a stage of sleep. An individual who's in a dissociative fugue is still conscious and reactive to the environment around them, but they're not going to remember anything that they had just done, and they're probably wandering in dangerous ways, crossing streets without looking, doing stuff of that nature. Something that's not often in my own personal experience. I've seen it very much, but this is often related to a form of dissociation, which is, it seems like this amnesia disorder, it has a lot to do with just the nature of how the brain loses the ability to encode memories when in a dissociated state. One more disorder here in the dissociative disorders, which is depersonalization or derealization disorder, which is when someone's having persistent and recurring experiences of either of these two experiences. One being depersonalization. We've talked about depersonalization a few times already. This can happen during panic attacks. It can also happen as a part of PTSD as well. Which is basically a sense of detachment, or being kind of feeling like you are outside of your own self with respect to your thoughts, feelings, sensation, physical body, or action. This is a very difficult sensation to imagine unless you've experienced something like this in the past yourself, but basically you just feel detached from your own body. You don't feel like you own your own self to an extent. But it's not really a belief. It's purely a sensation very often of just not being inside your own body anymore, even though you can still control yourself. So it's a very disorienting feeling. Hence why it's oftentimes associated with panic attacks, because many people can become very worried or distraught when these feelings happen, or even feel terrified by it. The other dissociative experience is derealization, which is feeling detached from one's surroundings. Individuals or objects seem unreal, dreamlike, foggy, lifeless, or visibly distorted. Some people may just say that things feel very fuzzy all of a sudden. That's probably going to be the most often thing you're going to hear from somebody. People are not going to be able to describe these experiences verbally very well unless they know what these are. So it will be our work as clinicians to kind of do our best to understand if somebody is dissociating in one of these ways and help them put words to this and identify it better, because it's really just the feeling of being detached. Very disorienting and very confusing for people if they have this. Most often it is associated with trauma or anxiety of some sort, but this disorder is about people who just experience these on their own without panic attack occurring necessarily. Another important thing to keep in mind with this is that reality testing is intact. And what reality testing is whether or not somebody can tell you, or express, report the reality of their situation, right? Now, if somebody was telling you that they were detached, that there was a puppet controlling their body, and that they weren't in control of themselves at all, and they were convinced of this despite evidence, that would be a delusional. That would be when reality testing is not intact, when somebody's reality is tentative, or their perception of reality is tentative, right? Most people aren't going to tell you that. If they're having just a depersonalization episode, they'll tell you it feels like they don't have control over their body, or they're detached from their body somehow. But they're not having these sort of delusions. That's how you know reality testing is intact. And of course, for this to be a disorder, like always, these experiences have to cause significant distress or impairment of some sort or another. If somebody already knows what depersonalization and derealization is, and they don't feel a tremendous amount of distress about it anymore, they just accept that they have these experiences, then we wouldn't really call it a disorder anymore. Okay, so I'm not going to cover tip 57 in super detail here. I'm just going to point out a couple of things that I found to be very important when reading those 20 pages of tip 57. There's also going to be a reading assignment associated with this, so I want to make sure to just highlight some of these key parts of tip 57 in case they may be on an exam at some point. So first, be aware of and know how to distinguish between the immediate versus the delayed reactions to trauma, right? Whether these are symptoms of PTSD or not. Tip 57 goes into a variety of dimensions, a wide variety of dimensions of how people's minds and bodies respond to trauma. Also keep in mind the 6 domains of trauma reaction. The cognitive triad is a really important one to keep in mind, especially because it can be so often related to depression as well. And hypervigilance and hyperarousal is also covered in a good amount of detail in that reading too. So read that as well so you can get a good feeling for what hypervigilance or hyperarousal would be and how to associate these things with PTSD in a clinical fashion. Also keep in mind and read through the dissociation and later development of PTSD, so all the ways that dissociation can be a part of basically a risk factor involved in developing PTSD later. You'll read basically about how if somebody does dissociate or disconnect from themselves during a traumatic experience, there's a higher level of them getting PTSD later. Also keep in mind the avoidance symptoms may be construed with low motivation and laziness, so this is kind of an important topic that they cover in the tip 57, which is just about how people perceive individuals who have symptoms of trauma and being able to really advocate for individuals with these difficulties. So wrapping up here, this is the lecture response assignment. Give me a very short answer on how do you distinguish between PTSD and acute stress disorder. I'll give you a tip. This is a very simple one. Just think about the duration of symptoms. You can take that a little bit further if you would like to, though, if you can find any other details that you find different between PTSD and acute stress disorder. Next, identify at least one way that acute stress disorder is similar to a brief psychotic episode. Now, that may take a little bit of extra digging right now since we haven't gone into schizophrenia quite yet. So I encourage you to go look around at brief psychotic episode and get a sense for it. And I'll give you another hint. This one also has to do with duration, but there's another little thing that you may pick up with brief psychotic episode too. And I'll give you another hint. It has to do with whether or not there's precipitating events related to these. So that's probably a bigger hint than I need to give, but go ahead and look those up. And then last part, briefly describe the difference between trauma and PTSD. So that was kind of the beginning of this lecture, where we talk a lot about the various types of trauma and whether or not they will lead to PTSD. And just give a brief explanation of that, no more than 200 words for that part. Keep this whole thing brief as usual. Lecture responses are not meant to be deeply, I don't grade these very scrupulously. I just want to make sure that you've looked through these lectures and that you've given a little bit of response in there. All right, well, that's the end of Lecture 5. Have a good week.